I'm Dr. Derek Lee. I'm happy to introduce Mr. Jason Bernard, who is a consultant orthopedic spine surgeon with Wimbledon Clinics and St. George's Hospital in London. Welcome, Dr. Bernard. How are you today?
Thank you very much. And good morning to you, Dr. Lee. It's a pleasure to meet you.
Excellent. Now, can you talk a little bit about your career path and how you became interested in medicine and eventually being an orthopedic surgeon?
Well, how I became interested in medicine, that's the easy bit. Many years ago, probably about the age of 8, I remember sitting watching, there was a program called Your Life in Their Hands, which is full of real life surgical stories. And I just sat there and I thought, that is very much the job for me. That's what I want to do. And never really had any doubts either way about it since then. So that was probably the single easiest decision of my life. That was easy. So surgery was a decision. I'd started off, I tried a few things early on, but orthopedics just had logical, mechanical, effective treatments. It was as simple as that. And the further I went into orthopedics, the more I realized that spine was something that there was so few people who were really providing a service, really underprovided. And everyone was being put in a bucket, if you like, of problem back or a chronic back problem. And in fact, I think we've actually seen in many ways a rejuvenation of spinal surgery in the last 20 years or so, led by some enormously hard-working people who've really searched for evidence for everything and started to put the bricks in place to actually support logical and thought out spine services. So it's been a great 2 decades to be doing spine surgery. And as some of the questions become clearer, and it becomes clearer that some of the questions are harder than we thought, but we like a challenge and we like being able to help people. As I said, the logical mechanical part, so much to do with the shape and growth of the spine is logical and mechanical. That it really exactly fits the bill.
Have you always had a bit of a mechanical brain in terms of hands-on or that?
Well, I think, yeah. I mean, I'm not one of these surgeons who built their own house, and I haven't built my own racing car, but I've done the odd bathroom and kitchen fitting. So these are the kind of things. And at the minute, the most I do is service my own bicycle, but that's related more to time than anything else. Yeah, so I quite like doing that kind of thing.
Okay. When were you first exposed to the concept of VBT and tethering?
Well, I remember, because it's the one and only time in my life that I've been to Anchorage, Alaska. And Dr. Samdani, he got up, he told us about the work he was doing. It was a moment, if you can imagine that you were in a medical conference and someone said, what I've got here is actually the cure. This reverses the process. This takes the very thing that causes the problem and reverses it. And up to that point, scoliosis has just been a progressive problem. It progresses until it's so bad that you're prepared to have a big operation with morbidity, and then that's you stiff for life, but it's still better than being stiff and off balance and out of shape. So it's one of these moments where you go, actually, this is a whole new ballgame now. This is a different thing. There's a possibility of actually curing and reversing the condition. And so it's very, very exciting. I haven't been back to Anchorage though. It's a lovely town, but in winter it was getting chilly even by September. So I imagine it's pretty grim in winter.
I guess it was worth the trip to Anchorage.
It was definitely worth the trip. Yeah, it was definitely worth the trip. So that was a very thought-provoking week.
So from that point onwards, did you start to kind of dive more into research? Did you speak to other surgeons regarding that? And how did that lead to VBT?
So that provoked an enormous amount of discussion about whether it was the right thing to do. I think everyone agreed that it certainly wasn't a wholesale change that was going to be made overnight. And I think the overall feeling was that there would definitely be a group of patients who didn't want to have a fusion, who were still growing, but had a big enough scoliosis already that they would end up having surgery, who may be interested in that form of treatment. And I think that was really the root of it, was saying, well, there's definitely a group here who will end up having surgery when it gets bad enough. And they may want to try this. If they don't want to, they don't have to. But if they do want to, then it seems unfair not to let them. You know, it's, as I say, if you've got something that might actually be curative, then you start thinking it might not be ethical to not offer it even. So, especially as, you know, it wasn't something that was mechanically outlandish. It wasn't something that relied on a completely new, it's not a new way of putting in screws. It's not a new approach to the spine. It's not a new method of correcting a curve as such, in terms of, you know, an anterolateral approach and correcting. That was the first method described really way back in the 1950s. So many of the aspects of it, many of the component parts were already well understood. So there was no real additional risk, if you like, in terms of saying, we don't know how to do that, we don't know how to do that, we don't know how to do that. It was more a question of saying, well, we already do that, and we do know how to do that because we already do that. And that's been around for a long time. And the only question was, will the flexible tether without a fusion lead to adequate correction? And if it doesn't, then what you're left with, well, it's the same fusion as you would have had. So it's not the worst trade-off. So I think that was really the other thing about it that was very exciting, was that it didn't rely on a completely unknown set of techniques. It was building on something that was already very much there.
With respect to VBT, why are certain doctors kind of moving towards going with that procedure and others aren't? Is it because of the approach, the thoracoscopic approach, where it's not necessarily done by a vast majority of surgeons who are used to the posterior approach? Is it that skill set that's perhaps limiting uptake as well?
Yeah, I think that there are many things that go on in the mind of a surgeon.
Okay.
And the majority of surgeons, strangely enough, for an occupation where you spend your time sticking knives in people and rearranging their innards, as my children keep reminding me is what I do for a living and how weird that is. Despite that, we're actually a very conservative bunch, and no one really wants to be seen as an outlier. That's important. If you're an outlier, you're doing all this stuff, no one else is doing that, then you're very exposed, because you're outside of a herd, is a way to look at it.
Sure.
And so you're very exposed. If anything goes wrong, then of course you're open to criticism from all directions. So we're quite conservative that way, much more so than you would realize. It's much more about delivering something reliable on time, rather than having a prima donna attitude. I think that probably went 30 years ago. You know, the media interpretation of the surgeon, the Doctor Strange, if you've been watching the Marvel movie series. You know, some neurosurgeons might still be like that. I think I know one who's a little bit like that, but by and large, that isn't how surgeons are now. So there's a great deal of conservatism. And so the first step is stepping outside the zone of comfort. Now, part of that may be to do with training, but there are lots of people, certainly in my generation, and I'm not that old, who did and still do anterior surgery fairly regularly. So that itself isn't that it's not taught or trained, but it certainly was less of an emphasis. The pedicle screw arrived, and by about 2005, almost everything had flipped around from anterior to posterior. And so, there is a generation over the last decade who maybe haven't done much anterior, but it's coming back, it's making its reapproach in the adult spine and now in the children's spine, because, you know, why throw away a useful technique or a useful approach? So there is a slight training issue. There's a training gap, if you like, but it shouldn't affect people who are, anyone who's 50 or over will have been exposed to these techniques through training. And so for them, it's not a question of training gap, but it's a question of saying, I've got something that works, it's reliable, it's worked for me for 10 or 15 or 20 years. What's the incentive to change that? Because I'm doing this and it works. And the only incentive to change it is if you look at the kids coming back into your clinic and saying, well, you know, they don't move quite normally. They're very stiff. And when they bend, you can see they're very stiff. And they've got a scar on their back, which, you know, short tops and things, that exposes the scar. And there's a lot of youngsters still wear ponytails because they don't really like that bit of the scar. And so, you know, you notice these things and ask them. And in some ways, it's about having another string to your bow, isn't it? It's being able to say, well, I can do your scar there, or I can do your scar there. Do you have a preference? You know, if all the other risks are equal, then it's just another choice in life. You know, do you want the zipper on the front, or the zipper on the side, or the zipper on the back? Even if you were selling an item of clothing, you would say, well, there's a choice. Let the customer decide. So there's an element to that too. But it's mostly about having a degree of dissatisfaction with the outcomes of fusions. And it's not to say all fusions are a problem. Some fusions have got fantastic results and really normal function, move very normally, no problems. The longer the fusion is, the more of a problem it is, clearly. The more muscle damage you do posteriorly, the stiffer you are. And there's almost a dose-response relationship between going into the lumbar spine and stiffness afterwards. You know, Peter Newton's looked at that amongst other people. So it's definitely there. And so if we can avoid fusing lumbar spine, especially, then that's good. But it also gives us an opportunity to treat these curves earlier, I think. So rather than saying, oh, it's 45 degrees now and quite flexible, but it's not a clinical problem for you yet, but it will be. And when it's a bad enough problem, you can come back and I'll fuse it. You can say, well, I can do something through some pretty neat incisions while it's at this small flexible stage. And that will probably stop it ever being a problem. That's as you think of it like an internal bracing almost. So those options exist now. The Pandora's box is open. And in many ways, it's a question of how you are going to introduce patients to those concepts. And purchasers and insurers and other people who are paying for it. Because they want to see that a treatment's effective and doesn't always need to be redone. You know? So that's an important part of it. I've wandered a bit from the original question, but why don't all surgeons do it straight away? It's mainly conservatism and wanting to stay right in the middle of the head and not be an outlier. It's partially a lack of appreciation that fusion isn't the perfect solution. It's a good enough solution. It's quite a good solution, and sometimes it's a really good solution. And sometimes it's the only solution, but there might be a better one that leaves you a bit nearer normal. Yeah? And that's, I think, what the aim of any kind of doctor working in this field has to be, how normal can we get you at the end of the day without taking too many risks for revision? And that's always a balance. And so there's some people who are not convinced yet that it's got a low enough risk regarding revision. Some people aren't convinced enough yet that it works. We've all seen some that have not worked and that have ended up looking really bad because they've got a progressive curve and there's metal screws in it, you know, and they need a revision for that. So we've seen that. And most of that's just actually just selecting or allowing people to select inappropriate cases, you know. And the selection goes both ways. There's technical criteria that if you transgress those technical criteria, it won't work because the technique has limitations. And so you have to be strict about that. And then there are individuals whose mindset is not right for an operation you might need to redo. They're bad at dealing with uncertainty. And maybe they actually don't care about the primary goal. They maybe say, I don't mind being stiff. I've got one girl who writes to me every year pretty much to tell me how well she's doing at university, and she's doing rowing. And she says, brilliant, I've got such a stiff back, I can row really well. Yeah? So some people really love their fusions. Yeah? And we mustn't, I've got another boy who does weightlifting. He sends me pictures after his fusion. And he says he can lift just as well. So, so we mustn't, it's not an all or nothing, but it's about gradations of what are you looking for out of your operation, or what do you want to achieve? What do you want to avoid? Where are the pitfalls and where are the risks for you? So it's all about just trying to do it better. And if you're going to do it better, it requires a lot more dialogue with your patient. You can't just tell them, this is the treatment, this is what you're having, because there are ups and downs to everything. And I have to start exploring what that patient in front of me actually wants out of it at the end. And sometimes they just, I just want to be more normal. Just make me normal again, make it all go away, and I'll be happy.
Right.
And that's what we're aiming to do. That's what we're trying to achieve at the end of the day.
Okay.
And it's another tool that I think helps us get closer with some of the kids. Not all of them are suitable, but some of them, they'll get closer to normal this way.
And speaking of parameters, what are your parameters for VBT in terms of that classic or perfect case?
So I have to say, I think that the biggest benefit probably is in the lumbars. I think, and the double curves, because they've got the most to gain, and if you like, the most to lose by having more spine fused. And it's also, there are technical advantages because you can use a bigger, stronger screw, and so you can get a better grip of things. I have personally found that whether you're going Risser 0, 1, 2, 3, they all work pretty well. Tri-radiate open is sometimes completely brilliant and sometimes unpredictably good at correcting. And so the only revision I've had to do for my cases was an overcorrection. Who started with a tri-radiate open. And she's great. She's ended up at 0 degrees for her thoracic spine curve, which is great. So I'm very happy with that. I obviously pulled the cord at just the right time. Not my skill, more just a bit of good fortune, I think. But I think that you can get good results in a variety of age groups, but the spine has to be flexible. And I think without flexibility, it definitely doesn't work. And I think for me, there's no point in preserving a disc that is already wedged. I think if a disc is already wedged open, it's not going to correct, and it's already too late for it. That's my feeling. And so I think if you have 2 or 3 wedged discs through the apex, I think it's not going to work for you. Now there are other things you can do, and you can do anterior fusions for them or an apical fusion for them, but it's not pure VBT. And I think for pure VBT, I think what Dr. Samdani first came up with and said Risser 2 or younger is a pretty good rule of thumb. But I'd go to 3, but I think that's the ideal group.
Depending on flexibility.
Yeah, that and flexibility. And there's a curve magnitude problem as well, because that 60 degree there's a reason for that, because there's only so hard you can push on these screws. They're young, the bone is usually quite soft. And so if you're trying to rely on a lot of force through those screws, it's not going to work. You're going to end up loosening them too soon. So that is a technical limitation on curve size. But size and flexibility tend to go together. And if you've got a really big curve, it tends not to be flexible enough anyway. But if clinically, and this is something that you've got to remember, so if clinically it's already a stiff piece of spine, when you bend and move during examination, if it's already stiff, you're not going to make it more flexible by operating on it. It's still going to be stiff after. So that might be a better indication for a fusion. And if you've got a substantial rib prominence, then you've got 2 options with that. Either you say not suitable for a tethering operation, or you say I can do a tether, but I will have to do multiple level costoplasty at the same time, which works okay, but it adds to the pain, adds to recovery time, and is not as practical to do thoracoscopically. Not impossible, but not practical.
Absolutely. If we go back to your preference for lumbar and double curves, and if there's significant disc wedging due to stiffness and severity of the apex, do you do disc release in the lumbar, or you try to stay away from the lumbar? Do you do primarily disc release in the thoracic?
Yeah, so I'm a little bit undecided about lumbar disc release because they almost always are flexible enough to correct.
Okay.
But what's in my mind is, will they stay corrected? Because you got to remember, any implant that you put in to the moving person is going to wear out or come loose at some point. It's everything in orthopedics tells us that. If you put it in and fuse it so there's no movement, then it has to last a year or so and then it's done. It's irrelevant after that. But if you're putting in a moving part, just like in a car, it's got so many miles in it and then it'll be done. So whatever you do to the spine, so you can correct it with the instrumentation. But something has to happen to make a permanent change in the spine by the time that instrumentation has done its time. And so that might be 2 or 3 years at the minute. With new generation technology and better strength cables, which are coming out for example, Globus have got a better thickness cable out. I say a better thickness out, a larger thickness cable out. So that will enhance the fatigue life of the instrumentation, but it won't make it forever. At least not to start with. Maybe with good engineering, it will last 20 years or 30 years, like a hip replacement. But ultimately, things will wear out or come loose. So when it wears out or comes loose, have you made a permanent change to the spine? So if you're Risser 3 or 4, there's really not much growth left. You're not going to grow out 60 degrees of curve in your remaining year. So at that age, I would say, yeah, definitely take out an apical disc and just fuse that one. Don't worry about movement. No one is going to miss one disc, especially not when it's already a bad disc. I don't think you can turn a really deformed, angulated, rotated disc into a normal disc again, and say we're doing mechanics, we're not doing magic,
Right.
So
you have to work with what you got.
Yeah, exactly. And if it's really out of shape and bent, you're not going to make it normal. Even if you push it in the right direction, it's not normal. So you're as well to just fuse that one, and then it's done. I worry about taking it out and not fusing it. I definitely, when I've seen MRIs after that procedure, there are inflammatory changes in the end plates. And even if it's not sore now, it's a disc that maybe is 20 or 30 years older than it would have been. It's like if you take the cartilages out the knee, it's not a problem straight away, but in 20 years it is. So I do worry about that. And we know what a fusion of the apex does. We know that's not particularly a problem. So I think for a disc that's too wedged in a patient that's a bit too old, I'd rather take it out. But if they're all nice squared up discs, and they're quadrilateral shapes, and they're a Risser 2 or younger, I'd rather just push it straight and not do any discectomies for that. And that's been successful so far.
Now going back to, so let's say it's a lumbar disc and the disc was already significantly wedged that it's not going to recover. So you would do a single level fusion at that point and remove the disc, or you would, how would you prevent?
Yeah, I would go as far as doing 2 levels. Beyond that, you might as well just do a fusion probably.
Okay.
But you often find that 2/3 or even 3/4 of the actual deformity is in those 2 discs anyway. But this is very much for the group of patients who are a bit older than maybe is ideal.
Right.
It's a bit stiffer than is maybe ideal, but it's what they really, really want to do. And this is the element of patient choice comes in. I think you're allowed to do that. The worst that happens is you get a revision to fusion at a later date, but probably it's going to be a good outcome, whatever. So I don't object to doing that. I think once you're post-mature and really adult, I don't think there's a real future in doing it then.
Okay. Now, for a double curve, for instance,
Yeah.
how do you approach that? Do you do single tethers on opposite sides, or it depends on, for instance, let's assume it's a balanced curve. It's doesn't compensate in the lumbar spine. How would you approach that?
So yes, the answer is single tether each side, and preferably in one sitting, unless there's any anesthetic issues with the breathing, because that's obviously quite important. But as long as the anaesthetist says yes, then it's both in one go. And I think you can reliably get the lumbar spine straight in those ones. And it's the thoracic spine you have to work harder. So I tend to do the thoracic first while I'm still fresh early in the morning.
Okay. Have you considered doing any hybrids like Dr. Peter Newton does in terms of selective thoracic fusion and tethering the lumbar?
So it's quite a nice idea, isn't it? I haven't done that. And I think I'm not too worried about the thoracic result, you see. I think that's why. And if I was going to fuse the thoracic, I'd probably just do it as an anterior fusion if I was doing it that way. Because again, you save a few levels that way. It's quite nice.
Mm-hmm.
You're typically going to stop at about T11 and T5. And if you're going longer, you might be T3, 4, and you'll start encroaching onto your thoracolumbar junction with your rods. And I think one of the reasons that the movement is more natural is that you don't damage all the paraspinal muscles. I mean, if you ever do a revision surgery for scoliosis posteriorly and see what the muscles are like, you realize they're not in good condition, you know, they're not what you want them to be. And there's a transitional zone where you go from the fused segment into unoperated muscle, and that can't be functioning normally. So I think if I'm going to mix methods, I'd rather do it anteriorly than back and front, because I think the advantages come from avoiding the paraspinal muscles and keeping the stiff segment shorter. And anterior fusion can work very nicely in those flexible cases that are too old for VBT. Anterior fusion can be really, really very good. And I've seen them where you wouldn't know they'd had an operation. You know, they touch the toes a couple of months and move very normally. So, and it restores the kyphosis in the thoracic spine very well.
Which is a challenge with tethering.
Posteriorly, it's a struggle. The anterior one, you get your kyphosis back quite nicely. So I think the most important thing in all this, though, is to make sure you understand what that person in front of you wants to get out of it, you know. And you've got to keep coming back to that and saying, what do you want me to address? What fears do you have? What do you not want to do? And if you've got to make a compromise, these are the compromises you're making. More stiffness, less stiffness. Scar back, scar side. Possible risk of revision versus risk of long-term muscle damage in the erector spinal muscles. So you can put choices to people where simple binary choice, would you rather have this or this? They can understand that one choice at a time. And it helps me understand what they want out of it. And hopefully that way we avoid the worst mistakes.
Absolutely. Now, if I can just dive into the concept of disc release, because there doesn't seem to be any consensus on actually what that is. Because different surgeons,
yes,
right? So different surgeons do their own thing. What is disc release from your perspective?
Okay, so if I'm going to release your disc, I will take that disc out and fuse it and do a correction at that level so that it's squared up. That's, to my mechanical mind, that's got a certainty and an end point to it that I like. And it's got a very long follow-up fusion. And we know that once it's fused, that's no longer a problem level. Yeah? So I like all those things about it. And in some ways, just as we talk about less invasive surgery, maybe we could talk about less stiffening surgery or less fusion surgery. So you still might need some segments fused, but maybe just not all of them. Yeah? So I think for me, it's pretty much that's the answer, because if it's that wedge to disc, I don't think it's ever going to be a good or a normal disc. I don't think it's going to correct well with growth. And I think that the long term of denucleating the disc and waiting is not going to be as benign as we hope. That's what I fear. You know, discectomy in the lumbar spine is quite a good operation, but it doesn't leave you with a normal disc. Yeah? And there's quite a modest rate of lower back aches from that in the longer term. Yeah? And any other situation we can think of where you accelerate the aging process in a disc, we tend to think that that's probably a bad thing overall. Yeah? And so denucleating a disc is in many ways aging it by a few decades all in one go. So yes, it gets movement out of it, and yes, it will heal with some fibrous scar and cartilage tissue, but what it won't heal with is a normal disc. And so for me, I have enough uncertainty about the goodness of that outcome to make me say that I don't really want to do that to people. You know? I'd rather do something I know what the outcome is, or say this is not the right thing for you. Now, I could turn out to be wrong. And we might be sitting here in 20 years' time, a little bit grayer, yeah? Or we might be saying, gosh, those guys got it right, and just denucleating the disc was exactly the right thing to do, and it doesn't cause problems long term. And that would be a wonderful thing. That would be a great thing to find out. But I have fears that the way to find out is probably not to do it to everyone. And I think so we have to be circumspect, let the patients who want that find the surgeons who think it's a good thing, yeah? And between them, they'll help us find the answer. Yeah? I think that's the only way you can realistically do this.
Makes sense. With respect to the tethering of the lumbar spine, it seems that some surgeons are adding a second tether due to
but that's born out of implant strength. So remember I said earlier on that implants have got a fatigue life. Mm-hmm. They're going to wear out, come loose, break, stretch. Now, we've got to avoid bad thinking. So if the reason that it all loosened before the spine was a new shape was because the spine was never going to be a new shape, then it was the wrong operation. And putting in 2, 3, 8, 15 tethers is not going to make a difference to that. Yeah.
Right.
So question 1, was it the right patient for the technical abilities of the procedure? Which is why I talk about the discs and the flexibility. Because if you got that wrong and the patient's too old, there is no number of tethers or cords or screws that will make it the good operation for them. Yeah? Now, if you've got someone who is flexible and young, then single tether is definitely enough to produce a correction. And I don't think there's a problem with that. The older group, I think the question is, it comes down to the state of the discs. And I think if you're thinking about doing a double tether, probably it's a better idea to take out the wedge disc or suggest a different procedure. So that's what I think, is it's not the right answer to fatigue life. There is a better answer to fatigue life, which is you get the engineers to design a more resilient tethering cable, which they have done and they'll continue to do. And the next problem, if you make a resilient enough tethering cable, is the screw will come loose or break. This is engineering in real life, is that there is always a weakest link. Yeah. Yep. And so the engineers like the weakest link to not be the bit that you can see breaking. Yeah. Or they like it to be the bit that's the least inconvenient to fix later. Yeah. So if you make the cable really strong, then a screw head will break off, which sounds benign enough, except that trying to get out the broken bit of screw is then a bit of a pain because it's buried in bone. Right. So the engineers protect us from ourselves sometimes, and they design it so that the weakest link is the most fixable link. Yeah? But they'll beef everything up. They'll get it to about a 5 to 10 year fatigue life. But even if you do that, you've got to make a permanent change to the spine with your first operation. And that either has to be because there's enough growth and flexibility that it will growth modulate, or it has to be because you have changed the shape of the spine on day one by taking out the discs that are wedged open. Yeah? It's as I say, these things, they appeal to my mechanical and logical side.
Yes.
And so I think the decision making rests on those features rather than how many screws you can put in.
So since you do consider going to Risser 3, you'll consider Risser 3 as long as there's enough flexibility, and you feel that the health of the disc is enough that from the day one of correction, you have a chance of it being stabilized long term, correct?
Exactly.
Okay.
I think the long-term result's important, and we don't want to have 90% of people having revisions, you know. I think 10% of people having revisions is about the acceptable limit. And I think if it goes much lower than that, or much higher than that, sorry, it won't get wide acceptance. You know, I think that's realistically, these are the kind of operations, they are still big enough that you still only want to do it once. Yeah. And people ask me, you know, they say, oh, it's less invasive, it's minimally invasive. But, you know, it's still a 35 millimeter titanium screw, and it's still about 5 to 10 millimeters away from your spinal cord, and about 5 to 10 millimeters away from your major blood vessels and your lungs. And, you know, you might describe it as minimally invasive or less invasive, but that's, you know, that's talking about the muscle and skin. The bits that really, really, really matter inside, you know, the big complications, those risks are definitely not less just because you're coming from a different direction. So I think we've got to keep that in mind as well. Is how we think about this is the spinal work is just as invasive. Yeah? The skin work is different, the muscle work is different. The spine, where all the big risks are, you're doing something that's just as invasive.
If we go back to Globus and then them beefing up the tether, are you using the new thicker tether right now?
So I haven't got hold of it yet. I think they've got to get it marked for Europe still.
Okay.
It should be available in the next month or two, I think. But yes, I would. But I would definitely use it because I think a bit of longevity is a good thing.
Is it just that the diameter that's different, or is it a new material that they've come up with? Do you know those details?
I haven't got those technical specifications yet. I think until they have it all approved, they're not going to tell me the full details anyway. I think that remains, what do they call it? Anyways, I think it's company data.
Yes.
Not allowed that at this point.
Well, I'll have to send you an email in a couple of months so you can give me the lowdown.
Yeah, absolutely.
All right. A question for you, since we're talking about revisions and tether breaks, etc. I assume surgeons keep track of that data all the time. Can you perhaps talk about that with respect to your experience? Yeah.
So definitely you're going to see some breakages of tethers. Yeah. Now, the majority are not really affecting the shape of the spine. And that's the way to look at it. Things might change by 5 degrees. And in fact, the younger, I've had a look at the results from my slightly older and slightly younger patients, and the younger ones, they seem to just go on improving steadily. The older ones are the ones that have a bit of bounce back. And so I think it doesn't change the overall result to have some tether breakage. There's a few people where it does make a difference, and you can fairly easily revise that from a technical point of view. Funding may be an issue, obviously, but the actual technique is not as difficult as you might imagine. But you may have to consider why that tether didn't survive, and it may be that there was not enough flexibility in the disc at that level to correct, or that there wasn't enough time for it to correct before it gave out. So I've got one youngster who's still very much growing and has a tether breakage, and he will either need to have revised one way or the other. But it's not because he's not got a flexible spine, and it's not that he hasn't stopped growing. It's just that actually the fatigue life of the implant wasn't enough for him.
Mm-hmm.
So that can definitely happen. And that's why enhancing the fatigue life a bit is going to be worthwhile. And enhancing it as much as is reasonable in engineering terms is a good thing to do, because the device ought to be able to reliably get someone through their growth years. And so that maybe means 3 to 5 years of implant life. Yeah? But beyond that, if it hasn't worked, then it's going to break or come loose sometime. So from a technical point of view, if you do revise it, you've got to ask yourself, why did it break? And do I need to do something in addition?
Mm-hmm.
And for some of them, fusion would be a better answer, because the reason it didn't work first time was they were just outside the envelope.
Right.
They were maybe a bit too stiff, a bit too wedged in the discs. The correction was never quite there. So I've certainly seen ones who are a bit old. They've come from other places, but they've been a bit old, curves a bit stiff, they never really fully corrected when they first had it done, never got good enough, and then the tether gave way. And you've got to say to yourself that isn't a recipe for success. Just putting in a new cable is not going to fix that problem. Yeah? So I'll always ask the question, why did that happen? And if they're young and just growing and they've just worn it out because they've been active, you know, in a way it's a good sign, as they've been out doing things and running about and being kids and actually worn it out. And yeah, that's an engineering problem and that's a surmountable problem, but it's something that you're going to need to probably just put a new tether in, and that will solve that problem. Or did it fail because it wasn't quite the right operation, or it didn't achieve enough first time, and now it's too stiff and the disc's wedged and it's not going to go back to normal. So if you don't ask that question, you'll get bad revision results too. You know, so there is some thought goes into it.
Yes, absolutely.
Thought on both sides to get this kind of thing right consistently.
Now, do you anticipate, because right now VBT is not covered by the NHS?
Yeah, correct.
Do you have any perspective on perhaps if that will change soon in terms of, and if so, how long will it take?
I only have 2 or 3 words for you on that one. So roughly speaking, in order, it's Brexit, COVID, and NICE is quite slow as well. So I think between those 3 things, I think no one knows what's going to happen in Britain in healthcare, even in the next 5 years. My guess is that we'll see a big push towards cost containment and what's been called industrialization of medicine, but to try and get a small number of very big hospitals doing large numbers of very standard operations. So the kind of thing that's been piloted, if you like, by joint replacement surgeons, where they have a hospital that they might do 2,000 or 3,000 a year in that hospital and do nothing else in that hospital, but they have clean, reproducible throughput, and they get savings on the implant and they force costs down. So I think we're going to see a lot of that. And does VBT fit into that? It doesn't fit into it at the minute because it hasn't quite got that absolute certainty. It hasn't got it's the same operation every single time that you can do. If you say, I'm going to do a posterior fusion, I'm going to do T2 to T12, and I'm going to put the screws in here, here, and here, and it's the same every single time. So reliability may end up trumping any other potential advantages in terms of the providers or buyers' point of view. So I think the picture in the UK looks like those things. A lot of uncertainty, a big push towards mass production line type medicine. And I don't know what will happen after that 5 years. But that would be the NHS side of it. And the independent sector may go in a different direction, because how else would you go if there's 90% of people provided for by the NHS market? You've got to do something different, or you're just the same. So I don't know what the independent sector will do. But we're certainly left with a probably not funded in the next 4 or 5 years, I don't think, unless something odd happens. Fair
enough. It's the reality of today.
That was certainly, it looks like it. We've been 4 or 5 or 6 years with no, or something like that, 5 years without funding already. So, you know, no one's obviously in a rush to change that. So we should have to wait and see. And it may be in the face of overwhelming evidence that over the next 5 years, NICE says, yeah, we can do it for these strict indications. That's, I think, if I was betting, that's what I would say, is that overwhelming evidence will accrue in various countries around the world. And in 5 years' time, it'll be NICE says yes for these indications.
Okay.
That's an estimate. That's an estimate and a guess. And do not put any money on that. It's not a tip at the races.
Well, Mr. Bernard, thank you for your time.
Thank you very much.
I've learned a lot. I always do when I talk to surgeons like yourself, and I really appreciate your perspective on VBT and how your brain works and how you analyze a particular case, choose the particular procedure for the particular person is what it's about for you.
Yeah, and help guide them through what is a bit of a maze nowadays in terms of decisions to make. Because, you know, I have so much sympathy for, it's like if you asked me to do my own taxis, if I didn't have the accountant to guide me, I'd be in jail probably. So it's very much the same. You've got these families who they've just found out, for them it's the biggest problem in their life at the minute, and there's all this haze of information and you don't know how to make a decision in that. So I think just to help them to form their thoughts, understand what is and isn't possible, and what the risks and what the potential benefits are, and what choices are realistic and what aren't. I think it's as much being a guide and helping them to not make decisions they didn't want to. I think that's almost as much as that's as much of the benefit as anything else, actually, I think.
Absolutely.
Yeah. Well, I hope your boy does very well. I'm sure he will.
Yes, he's doing well. And
Dr. Samdani is very good at this now, so I'm sure he's got the very best chance.
Absolutely. Right. All right. Thank you very much again.
And stay in touch, because yeah, I would like to speak to you in a couple of months once I get more from Globus.
Let's do that then. All right. Have a great day.
And Zimmer too. Zimmer obviously they've got their system as well, so we'll be having a look at that soon too. It's just been allowed for you.
Very good.
Right. So
all right.
Thank you very much then, Dr. Lee, and enjoy your breakfast. Thank you.
Thank you. Thanks, Mr. Bernard. Bye for now.
Bye.